So, again, a lot of this has been previously discussed. Leading cause of death for all persons age 1 to 44. What do you die most commonly from? Your brain injury, not your hemorrhage. Hemorrhage is the leading cause of potentially preventable death, multiple organ system failure, trimodal distribution. You guys all just heard this. Don't need to go through it again. Motor vehicle crashes are still the leading cause of injury in the United States, although for the very young and the very old, obviously falls are becoming more prominent, and as our population ages, obviously we all are seeing an increased number of geriatric patients in trauma centers and non-trauma centers everywhere, so falls are becoming much more predominant. When we talk about injury, we talk about by mechanism or by intent. So mechanism obviously being your blunt versus your penetrating or your crush, and your intent being intentional injuries, meaning your assaults, your suicides, as opposed to unintentional injuries. And we don't use the word accident because that implies non-preventability. We don't like that. So again, I apologize, some of this is repetitive. The primary survey, the ATLS tells us primary, secondary, tertiary. The primary survey, we'll go through that a little bit because it's what I have to talk about. But obviously, we all know what the ABCDE is. I always, whenever I talk about it, are most of you guys in the room surgeons, or are there a bunch of non-surgeons as well? Are there a bunch of non-surgeons? Yeah, okay. I always make the joke, I'm like, because we're trauma surgeons, we're not particularly smart. We can't remember, we can't go beyond E, so we stop at E, move on and do something else. But, so for the surgeons in the room. But obviously airway, breathing, circulation. I'll tell you a funny story actually, since I blow through some of this. I'm sitting in our trauma resuscitation area one day, and there was a orthopedic textbook sitting there on pelvic fractures. That was just sitting there when the residents had left it there. And so I'm like just flipping through it. The first chapter is resuscitation of the trauma patient. They're talking about the ABCs of trauma: airway, bleeding, central nervous system. I was like, seriously, guys, you couldn't even get that right? I mean, how hard is that? It's A, B, freaking C. Anyway, all right, question number one. A 66-year-old female presents to the emergency room after a mechanical fall from standing, striking her head. She has a GCS of 3. You immediately proceed with oral endotracheal intubation. The best way to confirm placement of an endotracheal tube is going to be, and again, apologize for the repetition here, auscultation of breath sounds, end tidal CO2, chest radiograph, O2 sat, or expiratory tidal volume as measured. And if anybody got that wrong, 2 people. Obviously, end tidal CO2 is now considered standard of care. We actually use it on all of our non-intubated patients as well to monitor them. You can just do a little side stream through their nasal cannula. Obviously, very helpful. Again, a little repetition here. Who needs to have their airways secured? Well, this guy, probably. Potential loss of the airway should be suspected in all seriously injured patients. Stride or labored breathing are important signs of airway compromise, and obviously your indications for airway interventions are going to be airway obstruction, inadequate ventilation, inadequate oxygenation, hypoxemia, your GCS less than or equal to 8, although I'll take some issue with that. And then this question of cardiovascular instability. Again, be very careful with the loss of the catecholamine surge when you administer medications. Your initial management is obviously going to be immediate clearance of the airway, your jaw thrust, insertion of an oronasopharyngeal airway, obviously nasopharyngeal being contraindicated in patients with midface fractures. Use an RSI approach. You guys just went through this. I won't go through it again. All right, question number 2. 45-year-old male presents to the trauma center following a motorcycle crash. He's obtunded with a GCS of 6. BP is 80/40, heart rate of 120. He's been intubated in the field. His end tidal confirms endotracheal tube placement. O2 sat is 88% on 100% FiO2. He's noted to have absent breath sounds. Tracheal deviation to the left, obvious crepitus of the chest wall. What do you want to do? CT scan of his head, administer packed red blood cells, a left needle decompression, stat chest x-ray, or an EFAST. All right, yes, needle decompression. Obviously, we're describing a patient who has a tension pneumothorax here. We want to immediately treat his tension pneumothorax. You don't ever, I'll show you a great chest x-ray that you'd never want to get in a minute. But yes, he's a tension pneumothorax. I'll go through what the wrong answers were, hopefully in the next couple slides. If I don't, just let me know. If there's something that you guys thought was correct and I think is not correct, just please let me know. So when we go to the B, right, pulse oximetry, end tidal CO2, supplemental oxygen, this has actually changed. It used to be supplemental oxygen to all trauma patients. Now it's only trauma patients with hypoxia. That's actually new, and that's based on a pretty significant body of data that hyperoxia is obviously just as bad, or maybe worse, particularly in the setting of neurologic injury. Obviously, you want to minimize your FiO2 to avoid hypoxia in intubated patients, and I will make a much stronger statement about hyperventilation. I have one of my former fellows sitting in the room who knows if I didn't say this, he'd fall off his chair. Do not hyperventilate a patient who does not demonstrate signs or symptoms of impending herniation. It is associated with markedly worse outcomes in the setting of traumatic brain injury. So I will come back to that, I think, in a couple slides. Importance, clinical signs and symptoms of respiratory compromise, obviously your tachypnea, your use of your accessory muscles, unwillingness to lie down is a big one. We see that a lot where the patient's like, I want to sit up, I want to sit up, I want to sit up. And that can be a very, very significant sign of impending respiratory failure. And obviously absent or diminished breath sounds. This is the chest x-ray you don't ever want to get. You're like, oh, wow, that was bad, right? Tension pneumothorax is a clinical diagnosis. It is not a radiographic diagnosis. The worst, even worse is when you get the CAT scan that looks like this, right? You're like, oh God, I'm such an idiot. But tension pneumothorax, right? Tracheal deviation, distended neck veins, absent breath sounds. Needle decompression is the immediate treatment, particularly the board answer. Obviously, in many modern trauma centers, you'll just put a chest tube in the patient rather than needle decompress them. But I believe the board answer is still needle decompression. And obviously in those patients who have urocult pneumothoraces, positive pressure ventilation, I would argue the board answer is if you have a patient who has an occult pneumothorax that is going to be on positive pressure ventilation, they should get a chest tube. Obviously in practice, those of us that do this for a living, the sliver of the pneumothorax we see on CAT scan that isn't on chest x-ray, we might not always put a chest tube in that patient if they're going to go to the operating room for their ankle repair. But the board answer for that probably is put the tube in. Your open pneumothoraces, much more commonly found in textbooks than ever in trauma centers, right? I mean, has anybody here ever actually seen an open pneumothorax? Yeah, I think I've seen like one or two maybe. It's just the sucking chest wound. The key is the three-sided occlusive dressing here. You don't want a four-sided occlusive dressing because then you convert their open pneumothorax, simple pneumothorax into a tension pneumothorax because the air can no longer escape. So you want this kind of flutter valve effect of a three-sided occlusive dressing is the classic teaching. Your flail chest patients, obviously, those are the patients with your paradoxical wall motion, right? 3 rib fractures with 2 segmental fractured segments creates a paradoxically moving flail segment. Treatment is initially supportive, as we know, but obviously it's very important to recognize the underlying pulmonary contusions that occur and the very significant risk of respiratory failure, particularly in geriatric patients. Your massive hemothoraces, they're usually not subtle. The diminished or absent breath sounds, typically these patients are going to have your flat neck veins though, right, because they're hypovolemic in addition to having potentially mediastinal shift. They don't get the distension of their neck veins like your tension pneumothorax patients will. It's obviously very easily seen on chest x-ray, but also with the use of the EFAST now, your 2 additional views with your ultrasound probe looking at the hemithoraces, you should be picking this up pretty early on in your primary survey. We talk about circulation. I really think about this as 4 elements. There's monitoring the patient, which is putting them on a cardiac monitor, evaluating their hemodynamics, getting their blood pressure, right, checking what their heart rate is. You want to be very careful with automated blood pressure cuffs, right? They are very unreliable in patients who are hypovolemic. Those narrow pulse pressure patients we've all seen, they come in with a blood pressure of 120/96. Those patients make me very nervous because the next one's 60. You want to obtain your IV access. 2 large bore peripherals are best. I personally recommend and I suggest that we avoid multi-lumen central lines in patients acutely in your primary survey. 2, short and fat is better. It's the only time short and fat is probably better. And most importantly, if you have 1 tube of blood that you can send, which tube of blood will you send? It's going to be your type and cross, right? The third part is diagnosing hemorrhage. Is this patient bleeding? And then the fourth part is obviously acutely, part of your primary survey is acutely treating any life-threatening hemorrhage that may be occurring before you move on to your D portion of your primary survey. There are basically 4 types of shock that we see following trauma, right? Hemorrhage, right? What are the 3 most common? Hemorrhage, hemorrhage, and hemorrhage, right? So you're always going to be ruling out hemorrhage. So hemorrhage, obviously these patients are tachycardic, they are hypotensive, they have altered mental status, cool, clammy skin. You want to be very careful with our older patients or even not so older patients these days who are on beta blockers. They may not manifest that tachycardia. And young people, as we all know, will compensate beautifully until they fall off the cliff. Neurogenic shock is going to occur exclusively in patients who have spinal cord injury at the T6 and above level. This is a sympathectomy that occurs at the time of their spinal cord injury. It does not occur in patients who do not have spinal cord injury. However, even if you have a patient who has a spinal cord injury, it's still a diagnosis of exclusion. The first three causes of hypotension following trauma are still hemorrhage, hemorrhage, and hemorrhage. Okay? These patients are bradycardic as opposed to tachycardic. They are hypotensive, but they tend to have warm, well-perfused skin because it's a vasodilatory state as opposed to a vasoconstricted state. Your obstructive shock patients, your tamponade, your tension pneumothorax, hypotensive, tachycardic, cold, clammy skin. And then, as we all know, we don't know if grandpa crashed his car and hit his chest or whether he had a massive MI, and while he was having his massive MI, crashed his car. We obviously see patients that come in a wide variety of cardiovascular dysfunction from non-traumatic causes or from blunt myocardial injury, which is pretty rare, real cardiovascular collapse from blunt myocardial injury. I won't go through the four classes of hemorrhage. You guys just saw that on the slide, and I don't actually believe in it anyway. I think your patient is your patient. Either they're bleeding or they're not. But a 53-year-old male presents to a trauma center from the scene in which he was a helmeted rider in a motorcycle crash. He is pale and diaphoretic. He has a blood pressure of 75/52 and a heart rate of 122. He has a GCS of 15. He's complaining of pelvic pain with an obvious unstable pelvis on exam and has obvious bilateral femur fractures. He denies any medical history and he's on no medications. Which of the following is not appropriate at this time? Administration of 1 gram of tranexamic acid over 10 minutes followed by an IV infusion of 1 gram over 8 hours. Give him a dose of Kcentra, which is a 4-factor PCC. Place a pelvic binder. Administer uncrossed match blood products. Call the blood bank to initiate a massive transfusion protocol. Which of the following is not indicated? All right, very good. So and I'll talk about each of these in a minute. Again, if I don't address why B is the correct answer here, please let me know. But currently there are certainly no FDA indications for administration of 4-factor PCC, even in patients who are coagulopathic with hemorrhagic shock. It is currently indicated for warfarin reversal. However, that being said, and again, I'll come back to this, there are many people who believe PCC potentially are beneficial in those patients who do have coagulopathy associated with hemorrhage. But that is not a non-evidence-based opinion, and certainly not what I would answer on the boards. So hemorrhagic shock, the major principle here is, and we see this, it was kind of first described in trauma, but obviously for those of you who do acute care surgery, we see this in our GI bleeders, we certainly see this in our liver failure patients, right? It's this development of significant coagulopathy that comes with hemorrhage. And it's the original description was the lethal triad, or the vicious bloody cycle, right? You have a patient, they're coming in, they're cold, they're bleeding, you give them a bunch of crystalloid, you make them dilute at their coagulation factors, they get colder because the fluids you're giving them are colder, they get more acidotic because you're using normal saline, and they get into this, we know who these patients are, right? We've all done this, we've all seen it, and they get into this vicious bloody cycle. And the concept now of trauma resuscitation is really to prevent this from occurring, because once this occurs, the mortality is about 80% once you truly have somebody who is hypothermic, acidotic, and coagulopathic from trauma. So it's really about preventing this from occurring, and can we actually prevent this? So I would suggest, as opposed to the slide that was up before me, that I would suggest to you that blood product administration should be implemented immediately in any patient who's suspected of having clinically relevant hemorrhage. All major trauma centers that I'm aware of in the United States, please somebody correct me if I'm wrong, have massive transfusion protocols or massive transfusion activation systems in order to alert the blood bank that large volumes of blood products will be needed or might be needed. And I would suggest to you that crystalloid resuscitation has now been demonstrated in multiple different forums to be associated with significant morbidity in the setting of hemorrhage. So actually we minimize crystalloid resuscitation and maximize blood product administration in the patient with hemorrhagic shock. there is some data out there, some of it is moderate quality, some of it is high quality, that there is benefit in administration of blood products in equal ratios of red cells, plasma, and platelets. This is the results, as you've heard, of the Properts trial. The Proper trial did not demonstrate a benefit with respect to overall mortality at 30 days, but did show a decrease in, or an improvement in what we could call hemorrhage-free survival, and that was by the administration of blood products in equal ratios that roughly look more like whole blood than the classic teaching of 4 units of packed red blood cells before you give platelets, before you give plasma. Taken together, those two concepts of minimizing crystalloid and maximizing the way you give blood products, the blood administration, to look as much like whole blood as possible, is typically what we call hemostatic resuscitation or damage control resuscitation. And I really think that that has become, I don't want to say standard of care, but that has become certainly the more common way to resuscitate a bleeding patient. And again, these are patients with hemorrhagic shock. I'm not talking about patients who come in with other reasons for hypotension and hemorrhagic shock. Additionally, there was the Houston trial, which demonstrated that patients who have penetrating torso trauma do better when you minimize crystalloid resuscitation prior to surgical hemostasis, for all the reasons we just talked about. That study was actually replicated in blunt trauma patients. I don't know if it's actually been published yet. I saw it presented, though. And so even in blunt trauma, this concept of assuming that a patient who does not have a terrible brain injury where you're worried about cerebral perfusion, permissive hypotension until hemostasis is achieved is perfectly appropriate way to take care of these patients. So how do we reverse the coagulopathy? Well, factor 7, out of favor, right? We don't use it anymore. PCCs, as I said, these are the protein complex concentrates. It is not currently routinely used for hemorrhagic shock, although some people do favor using it, but again, I would not answer that. However, its real indication is emergent reversal of warfarin, which is actually what its FDA indication is, and to reverse the NOACs. I learned this from my hematologist, the novel oral anticoagulants, right? I was like, why does everything have to have an acronym? But everything has to have an acronym, so. But the NOACs, keep in mind, not Pradaxa, right? Not dabigatran. Dabigatran is not reversible with 4-factor or 3-factor PCC. It's just for your, and I'm so bad at the generic names, I apologize for using the trade names, for your Eliquis and your Xarelto, your rivaroxaban and the apixaban or whatever, I don't know. But those are very effectively reversed with 4-factor PCC. So I would suggest that that is an indication, although not an FDA-approved indication. What about fibrinolysis? So you have patients, they make clot, and then there are patients who break down clot very rapidly, too rapidly, hyperfibrinolysis. It's a well-documented phenomenon that occurs in hemorrhage. And the only agent that's actually been shown to be beneficial in trauma patients is TXA, or tranexamic acid. The large CRASH-2 trial, over 20,000 patients randomized to receive TXA versus normal saline or non-TXA, demonstrated a mortality benefit for patients who were given TXA within the first 3 hours following injury. Interestingly, and I won't go into too much of the politics of this, if you gave it after 3 hours, it was associated with a slight increase in mortality. And interestingly, the benefit in mortality was not in hemorrhage deaths. So a lot of people are not necessarily huge TXA fans, but the best data that exists out there is that TXA is beneficial to trauma patients who are bleeding if administered within the first 3 hours following injury. I do want to spend a minute or two on TEG because both Dr. Frankel and I noted that this did show up on the boards, which I was really surprised about. So I just want to spend a minute or two. Do most people have some familiarity with TEG in the room? A little bit? Okay. So here, can you guys see both screens if I just point to one? So here, the top here is, so TEG and ROTEM, those are two commercial names of two devices. One spins the cup, one spins the piston. Functionally, they wind up, if you ask the companies, they're dramatically different, and one's clearly better than the other. But in practice, they do the same thing, whereas basically they show you pictorially and by measurements the formation of a clot. So here's clot initiation, here's your thrombin burst, here's the strength of your clot, and then if you take this out to fibrinolysis. And at the top here are the parameters, what TEG calls these things. The bottom is what ROTEM calls them. I would assume on any board exam that shows up, they would give you both in case you have familiarity with one and not the other. And this is what abnormal TEGs look like. So this is, if you see here, your time to initiation. This is kind of your fibrin monomers forming, and that's going to be your K and your alpha. The strength of your clot is measured by the MA, and then you take it out and you can watch the clot break down. So this, and I would hope that any board question they would ask you about this, they would show you the curves, because the curves are much more instructive than the raw values and the numbers. You really want to look at the curves when you use this clinically. This is a normal TEG. This very long time to clot initiation. This is something like a patient who has hemophilia or a patient who has significant clotting deficiency. This is a patient who's going to be on aspirin or Asprix. Totally marketing that, by the way. I'm just letting you know. Aspirin or Plavix, where you can see the MA, the strength of the clot is very low, right? This is very narrow. This is a patient that is has significant hyperfibrinolysis. They form clot just fine, but they break it down super quick. Here's a hypercoagulable patient, and then this is what DIC looks like in the hypercoagulable and then the hypocoagulable phase. And I want to just, because I like the study, I think it's actually a very nicely done study, but what do you do with this information? How do I practically apply this, whether it be on the boards or in your practice? This is a study that John Holcomb and the group in Houston published that basically looks at a bunch of different factors. So if your R value is the time to initiation, if that's real low, you typically will give, if that's real high, right, it's taking too long, the time is high, then you typically will give plasma. If your K time is high, those are patients that are thrombin burst, if they're not generating thrombin quickly enough to get that clot going. Those are typically patients who will benefit from fibrinogen and plasma. Your alpha angle is the kind of measures the angle of that upslope, so how quickly that is forming strong clot, for lack of a better word. Those are going to be your patients that you're going to want to give fibrinogen and then going into platelets too. And then your MA, or the strength of that clot, is going to be your patients who you're going to want to primarily give platelets to. And then if they're lysing very quickly, those are the patients that you would give an antifibrinolytic like tranexamic acid to. All right. So how do we treat these various forms of shock? We talked about hemorrhagic. Obviously, the treatment of hemorrhagic shock is hemostasis, right? That is the primary treatment, is getting hemostasis. I would suggest to you that 2 liters of crystalloid as ATLS no longer recommends, thank you, or 20 cc's per kilo bolus if blood is not immediately available is okay. But if you have blood available, blood products are first line, and then your damage control resuscitation techniques. Treatment for neurogenic shock, first-line treatment is going to be fluid administration. The reason being, when they have their sympathectomy, they get massive vasodilatation. You have to fill that tank up. You have to maintain, they have a functional, significant hypovolemia, and then move on to your vasoactives. Your obstructive shock patients, you're going to want to relieve their obstruction, and then obviously your cardiogenic shock patients, your treatment's going to be largely supportive inotropes. Oh, do that twice. How do we diagnose hemorrhage? Okay, and this is not going to be rocket science, right? We look for obvious injuries. You always want to pay attention to your history, right? You know, when EMS reports large volume blood loss on the street, pay attention to that. Your chest x-ray and your pelvic x-ray will obviously give you a significant amount of information. Your FAST and now the eFAST, which I think basically has almost replaced immediate chest x-ray in the primary survey. And then we don't really, as you guys know, do DPLs, diagnostic peritoneal lavage, so much anymore, but we do in those patients in whom the FAST is equivocal. We will do a diagnostic peritoneal aspirate, where it's really a yes-no question, right? Somebody's hypotensive, I can't tell whether they have hemoperitoneum from my ultrasound. I want a yes-no answer about whether they have hemoperitoneum, and that's called a diagnostic peritoneal aspirate, pretty well described. How do we take care of their bleeding? Immediately, direct pressure, right? Rapid suturing or stapling, your topical hemostatic agents like your Quick Clot, which is actually commercially available. Tourniquets are absolutely 100% life-saving. I was reading something, there was actually a military surgeon from the 60s that actually called tourniquets the agent of the devil. Like, really? How did you feel that strongly about a tourniquet? But apparently he did. But now tourniquets are absolutely 100% first line. You know, lots of data from the military, not level 1 randomized trials, but lots of data from the military. This is really a pre-hospital application of tourniquets, and obviously in the hospital as well. Pelvic binders, hugely helpful, reducing the volume of the pelvis, stabilizing the bony pelvis. And then I put Roboa on here because I know many of you have probably heard of it, the resuscitative endovascular balloon occlusion of the aorta. This is basically a percutaneously placed balloon that goes up in the aorta, and it gets your proximal aortic control instead of opening the chest and cross-clamping the aorta. I put in there in the interest of kind of completeness. I think 5 years from now, that may be the board answer. Tomorrow or next month, it will not be. All right, so how do we address our injuries? Well, our massive hemothoraces, right? Who goes to the operating room? This is kind of your generic 1,500 cc's as an initial dump, or somewhere between 200 and 400 cc's per hour over the next 2 to 4 hours. Obviously, patients who are hemodynamically unstable with a positive FAST for hemoperitoneum belong in the operating room. There is no role for additional imaging in this setting, and surgical consultation for the purposes of the non-surgical critical care boards should be obtained. Your pelvic fracture patients, we know that there are certain fracture patterns that are highly associated with hemorrhage. This is one of them. You can see this is the open book pelvis, where you see very significant widening of the pubic symphysis here. These are patients, if you put them in a binder, you can see what happens to their pubic symphysis. It doesn't have to be a commercially available binder. It can be a simple bed sheet, but absolutely perfectly appropriate to do in your primary survey as part of your C for a patient who has an obvious unstable pelvic fracture is put them in a binder. Even if they don't have a pelvic fracture, it's okay. But it absolutely, when it reduces the volume of the pelvis by reducing those bony elements, it really does dramatically decrease their blood loss. Other immediately life-threatening injuries, obviously your cardiac tamponade patients, classic signs, your Beck's triad, increased JVD, jugular venous pressure, hypotension, diminished heart sounds. They get tachypnic, they are tachycardic, they are cold, clammy skin, pulsus paradoxicus. Obviously, you want to be very careful about intubating these patients. The classic teaching being taking this patient to the operating room, prep and drape them while they're still awake. Try to take an anxious kid who's just been stabbed in the chest and probably high on something to the operating room and getting him to lie still on the table while you prep and drape them. Yeah, it works out great. But when you intubate them and you RSI them, they do decompensate very, very quickly. Treatment is obviously going to be a pericardial window, or for true hemopericardium is going to be some definitive fixation of whatever caused their hemopericardium with sternotomy or thoracotomy. Pericardiocentesis is a perfectly appropriate temporizing measure, especially in EDs where they may not have access to a surgeon who is capable of doing the definitive repair of whatever has caused their bleeding. Disability, obviously rapid evaluation of their neurologic status with a GCS. We talked a little about this. Pupillary response, gross motor exam, and then a rectal exam. That's particularly important, or I would argue only important in patients who either have potentially penetrating rectal injuries or patients who have potential spinal cord injury. I am not a believer of everybody, just because you were unlucky enough to get thrown into a trauma bay, that you need a rectal exam. If you've ever been in a car accident and wound up in a trauma bay, you understand what I mean. This I will go back to, though, this signs of herniation. So when you talk about patients, they come in and you're suspicious for a severe traumatic brain injury, they have a markedly depressed level of consciousness. Who do you really need to be really worried about right away and initiate treatment right away, including hyperventilation? These are your patients who have dilated or non-reactive pupils. These are your patients with their motor component of their GCS is 1 or 2, sometimes 3. Decrease of GCS of greater than 2 points, a rapidly declining GCS, and those patients who are manifesting the Cushing's reflex of bradycardia and hypertension. The treatment for those patients is osmolar therapy, classically mannitol or hypertonic saline. Depends on whether you like savory or sweet, doesn't matter to me. Hyperventilation, bedside burr holes, and then surgical evacuation for mass lesions. Similarly, who needs a neurosurgeon? Who's going to have a unilateral mass lesion that requires surgical evacuation? These are going to be your patients who have typically unilateral pupillary abnormalities, a rapidly declining GCS, and those patients who have lateralizing signs. And that's obviously because that is predictive of somebody who has a mass lesion on one side or the other. It doesn't mean that somebody who's a GCS of 3 with fixed non-reactive pupils doesn't have a mass lesion, but these are the patients who have a mass lesion that potentially you can probably do something about by getting your neurosurgeon to the bedside. As a general rule for spinal cord injury, the specific management of their spinal cord injury can and should be deferred until other life-threatening injuries are evaluated and managed. The physiologic consequences of spinal cord injury, though, the risk of loss of airway, their problems with oxygenation, ventilation, and their hypotension from the neurogenic shock do absolutely require immediate intervention during the primary survey. But basically, as long as you protect their spine from further injury, you can pretty much go ahead and do whatever else you need to do. and then obviously exposing our patients and not allowing them to become hypothermic. Everybody knows the secondary survey, right? You got your ample history, start getting your lab studies, start getting your imaging. For the purpose of the board exam, I think that this is a really important point. If you have somebody and you've gone through your primary survey, you're now in your secondary survey, and something isn't right, they're in tidal drops or they become acutely hypotensive, in your mind, and I would suggest in your practice, go back to your ABCDs. Did their endotracheal tube just become dislodged? Did their occult pneumothorax just become a tension pneumothorax? Go back to those ABCDs. All right, a little bit about what IV fluids to use in these patients. Crystalloid, always, if you're going to use crystalloid, use an isotonic solution. Lactated ringers, normal saline are probably the two most common. Colloids really should not be used acutely in patients with trauma. You could argue maybe a week later when they're septic in the ICU, albumin's okay. But as a general rule, we don't use colloids acutely. Blood products, as I said, preferred for patients who are hemorrhaging, and then hypertonic saline. Lots of people have tried to find benefit of hypertonic saline in a wide variety of trauma patients. Really, the only patient population that clear benefit has been demonstrated is in those patients with traumatic brain injury for the purposes of intracranial pressure management. All right, question 4. 38-year-old males in your ICU, approximately 24 hours after a damage control laparotomy for a gunshot wound to the right upper quadrant. He's been hemodynamically stable since the operating room, normalized his lactate and base deficit. On morning rounds, the nurse tells you that over the past few hours his urine output has decreased and he's becoming progressively tachycardic and is febrile. Repeat labs are sent and reveal a lactate of 6, a base deficit of 7.5. His hemoglobin and hematocrit have increased from previous values without transfusion, and his coagulation profile is normal. No significant bleeding, spelled incorrectly, is noted from his abdominal dressing. Which of the following is most appropriate at this time? Take him back to the OR, CT scan of the abdomen, administer 2 liters of lactated ringers, administer packed red blood cells, or administer 250 cc's of albumin. All right. So I would suggest to you the correct answer here is repeat laparotomy. And this is something, when we talk about endpoints of resuscitation, right, normalizing their base deficit, normalizing their lactate, adequate urine output, if you want to use SVO2, correcting their coagulopathy, normothermia, those are our goals. But I would suggest to you when a patient is otherwise okay and something starts going wrong, I tend to divide it like this. And again, I do this in practice, and I think this is a safe board answer as well. When something's wrong in the first 24 hours, patient needs to go back to the operating room. When they're not behaving as they should be behaving, they're either bleeding or you missed something. And I think that's a safe bet. It doesn't mean that you wouldn't give this patient maybe a liter crystalloid while you're going to the operating room, but this patient needs a reoperation. Once you're beyond that, then you start talking about missed injuries, right? Missed bowel injuries, duodenal, retroperitoneal, and then after that, it's sepsis, right? Then it's their secondary infection that they got. But early on, it's a patient who's bleeding or something else isn't right.